Okay, let's go through this last case and then we can call it a weekend. This is my patient, Thomas. Same types of photos. I'll try to go a little quicker. Some of this might be repetitive. Again, I want to stress facially generated treatment planning. We got all these different digital smile design systems that we can design digitally, or we can do tooth setups like I showed you to determine the tooth position. But it's all about basic prosthodontic principles. Tooth proportions, incisal edge position, buccal corridors. You can do it digitally, you can do it analog. So here we go with our well-extended impressions. And I might have said this already, but let me repeat it. Whenever I'm going to do a full arch case, locator fix or screw retain, I'm going to make a backup denture because I don't want to tell the patient at the end of the day, after they've invested all this money, that we couldn't load the case and I don't have a prosthetic for them. I can't make a denture that I think is adequate on a digital scan. It just doesn't capture the anatomical landmarks. So this technique with my alginate, I have this big fat syringe. I'm just injecting alginate, overextending the borders into the hammer notches, retromylohyoid areas. And so using that technique, I could get a nice, well-extended alginate that I don't have to go make a custom tray and go border mold. I mean, it's going to be a temporary, so it doesn't have to be absolutely perfect, but at least I have all the landmarks that I could send the patient home with something that fits well, and it's not going to be falling out of their mouth. There's the lower arch. Just again, stressing centric relation is where we have to be. And for that reason, we can't just take these mush bites and tell our lab, do the best you can. Let's make base plates. Let's determine vertical dimension. Let's be able to take a nice bite in centric relation. So here's our models mounted in centric relation. I've opened the bite up, and I can do that predictably because I've taken a face bow, and it's not going to introduce occlusal interferences by just arbitrarily mounting the models. And again, this was before locator fixed. Let's see, I'm trying to remember the timeline in this. But this is what I would originally present. And that's so he originally accepted a conventional upper denture and a 4-implant snap-on. I'm thinking, I think I made this slide wrong. I can't remember if he was going to go for a screw-on or a snap-on, so let's just proceed. I think it was he didn't want to pay the money for the screw retained, so he did do a locator at a reduced fee. So we do our setup, we establish our midline, our incisal edge position, our buccal corridors based on the photographs that we've taken, establish our plane of occlusion, and make sure we understand where his transition line is. And then with these models, we are going to be able to plan our implant positions because we're not touching those lower teeth. It's going to be prosthetically driven because we've given the lab the information as to what the vertical dimension is and where the teeth are going to be. We can fabricate our guides off of that lower model, and we can also make an immediate denture. And again, all this is based on looking at pictures, helping us determine where those teeth should be in regards to his face. Here's our final setup. They're going to scan that. Just a couple different views of the setup. So just like the other cases, they're going to scan the model with the teeth, and then they're going to take those teeth off of there and scan the model so they can make a guide on a clean model. We're going to merge the files. We're going to put it, in this case, again, into co-diagnostics. This case, again. And what I just wanted to show is that just like we do immediate dentures, and we use the photos to determine that maybe this patient's teeth were too long and so we're going to change the incisal edge position, we can also do that digitally in our planning. So here's the plan that our designers came up with in order to propose a prosthetic. And then we're going to plan the implant positions based off of those tooth positions. Show us all the aspects of the implant. We could see the implants relative to each other. And because we want locator fixed, we don't want to tilt any implants. We want them all parallel to each other. Just some other, go ahead.
I mean, it looks like it's very important to have the implants parallel. So
Yeah.
would you consider maybe tilting them and get a custom made over locator abutment?
Well, they're not custom made. There's angled locator abutments.
Yes.
But because his bone was so good, we could put implants wherever we were and we could put them straight. So if you could put them straight every time. We only tilt them when we can't put any implants distally and we want to extend the AP spread, or if the bone dictates that we have to use an angle abutment. So
but you'd still, like in a situation where you need to tilt him, would you still consider that and get an angulated abutment?
yes, definitely. But you can't tilt them as much as you would for like a screw retain where they go 30. You'd want to go more like 15. Okay, so this just kind of depicts the pins that hold the foundation, the fixation guide in. And just some other views. Here's some views of the guide. This is a smile in a box guide that Strawman makes. The last guide we showed was the guided smile by Rowe. They all have the same kind of intention. And there's the fixation base for a guided smile. This is the osteotomy guide that stacks on top of it. We get our information about what parts and implants and diameters and the parts, the T-sleeves for the guides that we need from the planners, and we get a surgical menu that the surgeon will follow during the surgery. Now we've processed our maxillary denture, because this is going to be an immediate denture that the patient goes home with because he's not getting implants in the top. And here's our lower prosthetic, which is really a backup denture just in case something goes wrong. And so at the surgical appointment, we're going to do the extractions, the alveoloplasty, place the implants in a guided fashion. And in this case, this one's not an immediate load. This is a delayed load type of case. So we put him in upper and lower dentures. The implant placement was guided, but he's going home with upper and lower immediate dentures. So after about 2 months of healing, his implants are healed. They're nice and parallel. You can see he's got great keratinized tissue. So this is a case that we shouldn't have any problem with recession or bone loss as long as we're making a passive appliance. We're going to start over and make him a new upper denture because that bone is all healed and changed and shrunk. He's been wearing a liner in his denture all along the healing time. So here's our initial impression. Here's our impression for the lower. Zest has these white blockout spacers that will give you enough space for the cylinder. So in this case, that's what I used. And then we can pour a nice model up that actually has enough blockout for the final prosthesis. I'm sorry, back up. That's not for the final prosthesis. With that, we can make a custom tray so that we can take an impression. Another way to take an impression is a two-step. This is actually my favorite way because it pushes down the floor of the mouth, it extends the vestibules. So what I do is I take this Panasil putty in a stock tray. It comes out of one of those big machines, inject it into the impression tray. You put a cellophane spacer over it, put it into the patient's mouth, and they just start wiggling it around, border molding, creating extra space. We're basically creating a custom tray. Then we go to the lab and I grind out where the areas for the implants are, and then take a final impression of those white caps, and this gives us a really nice model. Now we're going to do a conventional method for making a maxillary denture. I still like to use gray stick compound, border mold. I think this is the gold standard for getting a great impression using adhesive. And I use this GC Coflex for my removable cases. Put a little pressure hole so we're not compressing that tissue. Just a little video of taking that impression. And it becomes even more important when you have a removable or a non-implant supported against these implant cases, because the opposing arch becomes the one that's going to get dislodged from our nice, strong, implant-supported types of restoration. Big disadvantage is that's the messiest stuff in the world. If you ever get it on your clothes, to throw the clothes in the garbage. Oh yeah, he took half hour to clean up.
That's old school rubber base.
Well, it's not the old school is the brownish colored one. But this is still old school too. I do removable impressions with polyvinyl, but I just never think it's as good as what I get, with this. Okay, so there's our final impression, capturing all the landmarks. Again, we don't want to invert these. I box these with this little magnet. I make a little putty pumice plaster mixture that I box the case with. Pour up our models, create a vibrating line, posterior palatal seal, carve that out. And then on the lower, from the impressions we got, I'm making a custom tray because I want a really accurate model for this LOCATOR Fixed. I put my white processing spacers back in. Alternately, you could put these scan bodies, which will come in more and more handy as the digital workflow is developed for this product. Place our adhesive, take a final impression. Now in this case, I didn't border mold because this is going to be a LOCATOR Fixed, so the borders aren't going to be as important, but the custom tray fits so nicely, it really gave me a nice final impression. We have to take the little white caps out of the impression, because if you pour it right to it, it'll just break when you separate the model. Again, box and bead this, and here's our master cast. Now, we have to do our bite records and video determination, so I just make a base, and in this case, because these are so tall, I didn't really need to make a wax rim. We go to the mouth, we develop our base plate, get it at the proper incisal edge position, mark the midline, mark the canines, take a Coist face bow, and I used his existing lower denture to kind of help me get this in the right position, because this looked good in his mouth. Then we're going to determine our vertical dimension of rest, take away 2 to 3 millimeters to our vertical dimension of occlusion, and then had to do just a little bit of adjustment to those little peaks that are sticking up to get it at the proper vertical and get them touching evenly. Took my bite registration. That's another product by Kettenbach called Futar. And so again, this Coist gives me the proper orientation of the plane of occlusion and the ability to open and close the vertical if I think I need to change that vertical in any way. Just a couple different views showing how much space we have. Now the other thing nice about this Kois face bow is that when you mount the upper using it, you have this jig that goes on the lower arch. And you can use that jig to set your teeth. Because sometimes you're setting teeth to space and then all of a sudden you look and it's canted and it didn't look like that on the articulator. When you have this, you can use that jig to set the teeth and make sure everything's parallel. So it saves you a lot of time of resetting teeth.